on to the cervical spine. Now, last week we talked about neurodegenerative disease, especially with respect to the spine. And I mentioned that, that this happens. It's kind of an outcome of, number one, living to a certain age, which I'm in, but also related to, in the evolution of humans, it's a product of bipedalism. Because when you stand up, it's very different, isn't it? You're standing on your hind limbs. Your upper limbs are now free for a whole lot of other things, signaling, manipulating, playing with tools, and that kind of stuff. But it puts enormous pressure on your spine. Your body's now vertical. All that pressure is being transmitted right down the spine. And where's it the most? Where there's the greatest curve. Where's the greatest curve? In the lower lumbosacral region. So is it any secret at all why most of the degenerative changes in the spine take place in between, well, the mid-lumbar to the mid-lumbar vertebra to the sacrum, okay? But also in the neck, because people hold the necks upright like this. And so also you'll see today, just like the lumbosacral spine, most of the degenerative changes take place in this case, in the middle and lower part of the cervical spine, not so much in the high cervical spine. And but this is the stakes are higher here than the cervical spine, because as this slide shows, and I can't find my little probe anymore, but anyway. So this, there's the cervical cord behind. You can see in the dorsal roots here, and you're looking at the first cervical vertebra, the second, the third, the fourth. These labels, by the way, are related to the spinal cord. The spinal cord is one or two segments higher than the vertebral level at the back, and but it's the fact that the spinal cord is there. In the lumbosacral region, the spinal cord ends at between the junction of the L1 and L2 vertebra. That's it. Beyond that, it's the cauda equina, the horse's tail. Those are all the nerve roots kind of drooping down and then exiting through various exit foramina on their way to the lumbosacral plexus and the peripheral nerves in the legs. But here, we have this long extension of the brain here, which is the spinal cord, and hence the risk here. It's not just a matter of nerve root symptoms, of a nerve root being pinched. You know, these are the successive nerve roots. There's the C1, C2, C3, C4, C5, and that kind of thing, all the way down. And it's these middle and lower ones that are the main targets here. But the other thing that happens is the spinal cord. It's right there. So any degenerative disease in the cervical spine, flattening of discs, bulging of discs, degenerative changes in the joints around in the cervical vertebra, if they crowd that spinal canal, which is this canal where the spinal cord goes along, it compresses the spinal cord. Well, what does that do? Well, it can cause trouble walking. I mean, acute enough to cause total paralysis in the legs. But usually, and I see this kind of walking around town in the post office from time to see people very kind of stiff walk or the legs kind of going out. It's either a stroke or this on the probabilities. And if it's affecting both sides, it's probably there. So this is the higher risk thing. It isn't just the nerve root, it's also the spinal cord. So you'll see examples of that as we go along, but it's an elegant actually drawing from a European journal. Forgotten which one it was, but I'm not going to show that right now. No, don't go there. Okay. There is a video this week. It's boring on the examination of the neck. It's not a good one at all. Next week's, when we do the carpal tunnel, there's actually a very good one because it shows you the endoscopic and the traditional, the endoscopic way of actually releasing the median nerve, and they do a very good job. But this week's, I'll tell you, the characters in it, the physician and the patient, are as dull as sin, and the subject didn't sound much more interesting.
Are you
So
trying to convince us to watch it?
yeah. So well, yes, we can watch it at the end if, as a wake up for you. Yeah. And so here's I really am lost without my stick here. But anyway, here's this could be any level in the cervical spine. So this is at the back, that spine. If you reach at your back, you feel these little spikes. Those are the tips. These are the spikes in the vertebrae. You feel them yourself here. And there's the spinal cord. You can see it normally. There's a fair bit of space for the spinal cord and the nerve roots here. These are joints here. Wherever there are joints, joints can degenerate, and if they can degenerate, the response to that is they tend to get larger and encroach on the nearby space, and they tend to crowd things, which may be symptomatic. For example, here, if you compare this side here compared to there, over here, I can't reach, but oh, maybe if I walk around. Yeah. So just compare side to side. So this is a relatively normal side here. But the soft part of the disc, we were talking about that over a little bit earlier, but the soft part of the disc, it hasn't ruptured through the outside, but it's kind of bulging in here, and it's compressing directly, just where the roots kind of combine to form a combined motor and sensory root here. So that could certainly cause symptoms. If that were the number 6, I mean, there are two very common, just as there are in the lower back, where the commonly affected roots are L5 and S1. In the cervical region, it's C6 and C7. So if this were C6, the person might get tingling in the thumb and maybe along the side of the arm. Or as one person told me in the bar, the Prince of Wales, a year and a half ago, because, yes, I was there, and he, his health had been very good, but he kind of reached out, and he felt this electric shock bolt right down his arm and into his thumb, and he didn't know what to make up of it, nor would we if it happened to us. And but so I was seeing him. Well, I saw him in the bar several days later, and he told me this story. The electric shock thing had all settled down, but I examined him in the bar, and it was obvious he had C6 because he had tingling and numbness right in the thumb. That's a telltale sign. You know exactly which root it is, and he had the weakness to go along with it, and that's what he turned out to have. When he had his MRI, we actually looked at his MRI together. So that telltale sign, but there are other things. There's a posterior joint here. I mean, there's a joint here, but there's another one back here. And there's the normal side here, but on this side it's kind of thickened. Oh, that's interesting, isn't it? A little thunderstorm. So that's that lifting of the air, the moisture by the cold, dense, retreating mass. This is the warm front, so come on in. So, so the point is that depending on wherever these degenerative changes that take place in bone, wherever bone is degenerated, it tends to get thicker, and that crowds space, available space. Or sometimes it's an acute, as with this one, with my friend, was an acute disc protrusion and that acute pain Fortunately for him, it didn't go backwards. If it had gone backwards, it might have compressed the spinal cord. Most of them don't, thank goodness. And so this is the kind of the general pattern, and we'll just look at a few levels here. So let's see where we go here. Oh, here we go. Okay, now I could go. These are kind of blurred here, so don't worry. But this is normal. Here's the spinal cord. This is the cervical spine. This is C1, C2, C3, C4, C5, C6, 7, 8, 9. They all look fairly normal. They're not, this is not what a spine would look like in your early 20s. It would look better than this. But there's the spinal cord hanging down there. It's got lots of space around it. It's hanging. The white here is water, spinal fluid. So there's lots of spinal fluid around it, lots of room to move. And even if this disc did protrude in here, there's still some give in the system, right? Yeah. And but if I go over here, and let's take this really bad one over here as a classic example. There's C1, C2, C3. C3 is the last normal looking cervical vertebra here. Look at this one, it's collapsed at C4. Did this. And this doesn't look normal either. And this one is kind of shattered. And you can see the disc protrusion here, right here. There's the spinal cord looking fairly normal. And then it gets pushed back here. So the spinal cord is actually compressed here. And even the next vertebra here, C7, is 7. 1, 2, 3, 4, 5, no, 6. So 5, 6. So most of his changes here are 5 and 6, and there's 7. And then it begins to look normal below that. See here? Okay. So it's where you expect the trouble to be in the mid to lower cervical spine, and that's where it is. But here, you're not looking at the roots here, but certainly there is evidence of spinal cord compression here. Now, whether that's symptomatic or not is another matter, but there it is. And here's another one. I mean, here, it's obvious the thing looks normal down to about here, doesn't it? There's the spinal fluid, a normal looking spinal cord here. But then, so what are we? 1, 2, 3, 4, 5, 6, and the vertebrae start to look broken up, a little abnormal, and there's some posterior, or at least disc protrusion going backwards. So this is an abnormal. There are disc protrusions here, and they're pushing on the spinal cord. So that's the general pattern, but certainly on the right here. Now the point is, I want to make here, there are lots of people who are asymptomatic that look like that right-hand slide. So you have to be very careful, as I tried to emphasize last week. You know, there are 3 ducks in a row here, diagnostic ducks in a row. First duck is what are the symptoms? Okay, my friend had tingling, and first of all, he had that electric shock feeling from his neck, so I knew it started there. And right down to his thumb, and that told me it was C6. So I already knew 2 important things. And I also knew he was moving his arms and legs fine, except for some weakness in that C6 distribution, so I knew his spinal cord was all right. And the symptoms actually told me the level, right, because of that thumb. So first duck are the clinical history. Second duck, the clinical findings. Well, getting back to my friend, he had weakness in the C6 distribution. I already knew from this that it was C6, but it was confirmed on the motor side. And I knew from the examination that the spinal cord was functioning fine. I didn't know whether it looked fine, but I knew it was functioning fine. And then the imaging studies, that's the order. And all of those ducts have to line up in a row. They have to make sense, interpretive sense, because there are a lot of imaging studies that look abnormal in our age group that are not causing symptoms. If the compression develops very gradually, I think I used this, maybe I told you the story last week of this lady from Switzerland, a very wealthy lady. When I was at Tufts University Medical Center in Boston, she came in loaded with money, very gracious lady in her mid-80s, didn't want to be there, wanted to be out shopping, quite mobile, and staying in a five-star hotel and wanted to party. She was there because her family were very concerned about her because she had seen a group in Switzerland and they had shared the MRI findings which she came, or her daughter came with a bag to show me. And I have rarely seen as abnormal an MRI of the whole spine in anyone. And I mean, that spinal cord was going bumpity bump, 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 bump along the backs of these protruding discs. But she was walking fine, she had no symptoms, and she wanted to get out of there. And she had her way. And she was very much with it. But when things happen slowly in the nervous system, if a brain tumor develops very, very slowly, or if the pressure goes up inside the brain, hydrocephalus, for example, in kids, if it happens very slowly, it's amazing. I mean, the ventricles may be huge, and just a ribbon of brain around the outside of the ventricles, but the person's functioning normally. So when changes take place in the brain slowly, the brain accommodates, and it does it very well. So the severity of the abnormalities you see don't necessarily correlate with somebody's symptoms, okay? So when you're trying to make sense of stuff, yes, it's important in this day and age, and we can certainly have the imaging tools for it, to look at the thing, and we can see it in great detail, but that doesn't help unless the story and the findings fit the imaging study. You follow? That's a very important thing, because it leads to a lot of mistakes in operating on people, because you're operating on something you saw in an image, and yes, it's real in the image, there may be targets, but has that anything to do with the person's symptoms? So why would you operate on something that isn't actually causing symptoms? Why would you do that? It doesn't make any sense. And but some surgeons have this mentality: well, I won't see that patient unless send me the MRI. And what they really want to know when they put up the films is this something I could operate on? And I have many friends in the orthopedic community, but they're the worst. I'll probably have fewer friends right now. Yeah, but anyway, I mentioned that because, well, there are other biases like that in medicine too, in healthcare. And you can't help in the early days when imaging studies came around, especially MRI, they were very beguiling. I mean, stuff that we guessed at for decades, all of a sudden we're seeing. I mean, nobody was looking at the spine at autopsy. I mean, that's a big thing to do that, to ask a pathologist to do that. And so a lot of the stuff we didn't know. I'm not trying to ditch the imaging studies, not by any means, but as I say, the 3 ducks in a row, that's the way it goes. I just put the pain in the back of the head, neck, and arm. Well, stress is a huge one. Yeah. You may have noticed yourself when you're under pressure, and your nose in the grindstone, the neck gets stiff and sore, or you're seated in some awkward position, you're on an airplane or whatever it is, and you can't move much, and then you get the stiffness in the neck and elsewhere too, and the spine. We've talked about all of this, and we're not going to get into this except that I will mention what I didn't show you in that, we'll go back. Okay. What I did not show you, I had a patient one time in Thunder Bay that had an extraordinary story. She was working on her thesis. She was in her middle age, but working on a thesis, and she developed this excruciating pain in the back of her head and neck on one side. I mean, very severe. And then several hours later, she had weakness in first one arm and then the other, and then in the legs. Why would that happen? Look, there's no equivalent in the lumbosacral spine. The blood supply to the hindbrain, the brain stem, comes through these vertebral arteries. There's a hole in every vertebra here to allow the artery to go through. And sometimes, when people kind of twist their head in a certain way, what will happen is the wall will develop a tear in the middle of the wall and then bleed into it. That's called a dissection. And if enough blood collects into that, it actually blocks the blood vessel flow. So you can have a stroke. And so that's what she had, a vertebral artery. So I mentioned this because the neck is more complicated. Not only is there a spinal cord there, but there are two major, in fact, the only major blood vessels, arteries, going to the hindbrain and the cerebellum here. And if something happens to them, then that's a potential cause of a severe stroke. And so I just wanted to add that into that, because is it common? No. Is it devastating? It certainly can be. So we'll just go along here. We won't. I just wanted to bring that up. Well, I've already said a lot of this stuff. I'm just going to mention the common nerve roots here because, where are we? I'm not the one. I want to go back. And back. Okay, this is the most common. This one and the next one are the most common ones. Well, of course, they all have pain and stiffness in the neck, so that has no localizing value at all. This does. If they had pins and needles, I've said this umpty times with last week, and I'm repeating it again this week. If you want a really precise clue to what is going on and where, this information, tingling and numbness, where it is, tells you what's going on. So in the arm, C6, C7, C8. Okay? So it may come down the arm to get there, but at the termination. It's like, remember in the foot I told you the big toe was L5. If somebody had tingling in the big toe, 95% of it is L5. And if it's in the lateral side of the foot, it involves the baby toe and the next toe, it's the first sacral root. Those are the two most commonly affected roots in the lower back. So the same pattern follows in the neck. So the two most common roots, as I mentioned, are number 6 and number 7. So the tingling here in the outside of the forearm, this here, and into the thumb. Just like that, that's C6. It's a giveaway. And C7, I told you, it just moves over to the index and middle fingers. Like my friend in the bar. Okay, and as I recall, he had weakness in extension of his elbow, so this, couldn't do that, that's C7. And also with cocking his thumb and the hand and the wrist up like this, that's C7 too. I remember checking that in the bar. So that's where my practice is these days. Well, it is interesting that where's your practice? Well, it's Wales. Yeah, yeah, and C8. C8 is less common than the other two, but I've already told you these two fingers. We don't have to read all the other stuff. Just remember that sensory stuff. It's the important thing. If spouse or you develop symptoms, what to pay attention to. Mm-hmm. Okay, the history is really important. If you're at all inclined to be forgetful, don't be. Write it down, or tell it to somebody who is going to write it down, because it really saves the next person who sees you a lot of grief at guessing stuff. So it's really very important to know what the first symptoms were, the character of the symptoms, and where those symptoms were. It's really important. And it saves people a lot of, well, we don't need to go through it, but these are actual cases. And so tingling and numbness in the middle and lesser extent index fingers, well, you know right away from what I told you, the C7, right? And while weakness in the triceps, that fits with C7. So, and it absent triceps, it all fits. So the story and the findings, remember the three things, fit together here. So now when you look at the MRI, you directly look at the level for C7 to see if there's something that would explain those symptoms. And what was it? Oh, sorry, I've got to skip this. This is the dangerous stuff, because anytime somebody describes an electric shock-like sensation, and you find the tender reflexes are brisk in the arms and the legs, or they've lost strength in their legs, tells you the spinal cord is involved, not just the root. Okay, so that's really important. And no, I'm skipping some of the stuff. Well, I'm going to go through a few things here just to illustrate some of the issues here, because here is in Thunder Bay. I mean, I used to look after patients with MS in London and at Tufts, but I really had a clinic of 1,500 people with MS in Thunder Bay. I shared it with a colleague from Kingston. And so, now, notice the vertebra all look normal. The discs all look normal. The spinal cord looks anything but normal. Because look at these white little fluffs in here extending right down into the upper thoracic cord. They're not continuous, they're kind of discontinuous. And there's a little patch of it in the brainstem here and in the cerebellum. And I could just bet the brain showed stuff. This is a patient with multiple sclerosis, and that characteristically causes an inflammatory, autoimmune, demyelinating changes in the brain, and you can see it in these T1 images, meaning the water's white and the tissue is dark. T1 images, so or T2 images, I should say. So it's clear this person probably had a lot of trouble walking like that, very, very stiff, balance off, broad-based gait, and depending how much in the neck, might have had some really awkward kind of trouble with their arms. And I mean, it can be a very disabling disease. Much better, much more manageable these days than it used to be. So there is hope on this front. And So that's, any guesses? Well, first of all, when you look at any films like this, just like a portrait or a piece of art, you have a way of doing it. You start with this, and then you move to this step, that step. Okay, but there's again, all the vertebrae look pretty normal, the discs look normal, but there's the spinal cord. But look at that thing
Yes.
up there looking white between C1 and C2. That's a tumor. That's a low-grade astrocytoma and the spinal cord. There's a transection right through the image, right through the middle of that tumor. And this person had very few findings. This person had this for, I think, about 5 years. His major symptoms were that if he coughed or sneezed, he worked in the bush, and if he stepped down heavily sometimes, tramping through the bush, he'd get this shock-like sensation into his arms and legs. The French, named after a French neurologist, Lermite, so it's called Lermite's sign, this electric shock-like sensation in the arms and legs. And the tragedy here, because this fellow was managing. He didn't have any weakness. He didn't have any imbalance. He was working in the bush, had been for several years, but he wanted to know what was going on, and certainly these electric shock-like sensations got his attention when he stepped down heavily, or he sneezed. Well, in the age of the gamma knife, that came out about 20 years ago, using gamma radiation as a form of a surgical knife. Something like this is unresectable physically. To go in and take that out, first of all, the borders around it, where's the border when you get in there? And the risk of damaging what's left is huge. So no neurosurgeon wants to operate on something like that. Yes, you can scoop it out, but then the person's quadriplegic.
Oh.
And then there was quite a lot of pressure from 2 major centers who had gamma knives, who saw this fellow, and thought, well, he's a good candidate. And I wasn't too keen about it, but I didn't have a lot of experience with the gamma knife. I do remember in my London days, every time there's a new toy that comes out, a new way of doing stuff, every center wants to have one. And there was a lot of lobbying in London to get a gamma knife. And Mac went through the same kind of thing. In Toronto, they got a couple of them. Anyway, so I just mentioned this kind of thing. The tragedy here, they raised his expectations. They did use the gamma knife, and he was quadriplegic after. Yeah, so it's an awful outcome. I mean, he should have been left until nature produced whatever symptoms it was going to do, because he clearly, with just a rim of the spinal cord here, was functioning quite well. It had been functioning quite well for a long time, and had every prospect of continuing to function quite well for a long time. Obviously, there's a limit to how much you can get by with, but anyway, that's what he did. But I just mentioned that because it tells a lot of stories in medicine.
Oh.
Well, this was a great colleague of mine, and a young fellow who was a chief resident in neurosurgery at Tufts at a time when I went there as an early staff person. And it shows you the trip-ups that happen, because if you look at this spine, sure enough, if you just look at this as a film, there's C1, C2, C3, C4, C5, so between C5 and C6, and C6 and C7, and C7 and the first thoracic vertebra, there's a bumpity bump, bump, bump. By the way, that Swiss lady had a much bigger bumps all the way down with no symptoms. So it wouldn't be unreasonable to conclude that these might be symptomatic, particularly in these two levels where it's actually touching the spinal cord. But Colonel Howman, he's an excellent fly fisherman, great sense of humor, but also perceptive. He looked at this and he said, well, you know, I don't want to operate on this because I don't think there's enough evidence that the cord is compressed here. Is there any possibility that there's a medical cause for this? And remember in Downton Abbey toward the end when Lord, whatever his name was, I've forgotten, developed pernicious anemia? Remember pernicious anemia? And it was pernicious in those days, meaning slowly developing sentence of death. And that's the way it was portrayed in the program and the way it was. But it's B12 deficiency.
Oh.
That's what they found here. And this person was put on B12, high dose B12, and lo and behold, the symptoms and many of the findings resolved. And so what it means is, listen, just because it looks mechanical doesn't mean it is. Which I know I'm drum beating the same point again and again, but the three ducks and Carl, and he was fighting his older colleagues over this, who thought, well, I know Carl, you're very good, you're keen and that kind of stuff, but look, and you should do something about this. Well, Carl, big smile on his face, and thought, well, pull off. And just the kind of doc you would like to have,
Yes.
personally, and a really nice person, good sense of humor. But it just shows you. And by the way, the images in the spinal cord there are actually classic, as it turns out, for B12 deficiency affecting the spinal cord. Vitamin E deficiency can do a similar kind of thing. And so all praise to Carl. And the only reason why I put this up is what do surgeons do about the spinal cord? Well, because, or the nerve roots in the cervical region, because the spinal cord is there, and because these vertebrae are kind of smaller in scale, the sizes are all kind of smaller and tighter, and you've got two big vertebral arteries, one on each side, I mean, it's high-risk surgery sometimes. So how do you get at it? Well, the classical one was to do what they do in the back, the lower back, go at it from behind or the side. And I don't have George with me here today to kind of illustrate that, but George gives his best wishes. But anyway, one thing is to go at it from behind and take the back off the spine, and meaning this part. Or there's the spine here, so the spinous process and the lamina here. So you create the space that way, or at least go at it there. They've kind of opened up a hole here for a nerve root here, and so that's a reasonable way to do it. But one of the things that came in my mid-career, which a lot of surgeons prefer to this day, is the so-called Clower procedure. Go in from the front. It's actually quite a neat way to go at it. And just move everything to the side, and the visualization is excellent, and the risk is a lot less, and it works very well. When I was looking at some of this stuff, my son was on call in Halifax, and he's the only laryngologist east of Montreal, and but they're expected when they take call to take anything comes through the door. And so we were talking on the weekend, and he likes being on call. You know, call is 1 week in 9, but when you're on, you're on, and you're likely to be called into the hospital and end up operating. But he likes that at this age, and you know, the resident staff are good. Anyway, he said, so I said, well, and he also, I mean, last few days I've been under the weather with a cold. But when you're Tim's age, middle age, 55, that's the last thing you think about. You're on call, that's your job, cold or no cold. Well, he was fine, and he had 2 cases that he told me about. One was, one of them involved, he said, was a gunshot wound. And somebody had been shot from the front here, and you know, from that first picture I showed you, there's a lot of stuff going on in there. And that bullet seemed to, the magic bullet, it seemed to find a way, it didn't hurt anything vital on the way before exiting through one of the ribs. So it was really, the person was shot this way, and it exited one of the upper ribs at the back. But that was a all-night procedure. And so he was very pleased with the result, and the patient was just fine. But as a side point, I said, well, how often are gunshot wounds? You know what's common there? Stabbings. So he's had several cases so far this year when he's been on call of stabbings, and usually in the head and neck kind of thing. And not so many gunshot wounds, but they never had a gunshot wound when he was a resident there. It's like Toronto's changing. It's Hamilton changing. Beginning to look more and more like the stuff further south. Anyway, so the surgical procedures have evolved a lot. But you can see, I mean, that gunshot, if you look, I mean, just look at that. Major blood vessels, the carotid artery is there, major venous drainage, all these nerve roots, and wow, there's a lot of things, and that bullet managed to miss them all. It's incredible. Well, the other thing is that, and I think Tim has seen, well, anyone in practice for a length of time sees stuff like this, this is a mass. It's an oat cell tumor from somebody smoking, you know, probably related to that, lung cancer, and right at the top of the, well, at the base of the neck and the apex of the lung, and then it goes into that plexus of nerves that we were talking about before, and down, and another one. Well, we'll just finish on here because we've got stuff to talk about, but I absolutely love this painting. I mean, it doesn't do it just for me to photograph it and then expand on it, but it's amazing. But it's also, if you look at the time, or it doesn't, 1901, there was a lot of industrial fog in London, so coming up with a foggy day in London town was almost a regular one. And 2 of my best friends in London, the Castles, when he was doing postgraduate work in England and she was doing other work, they were going to meet. And one was on one side of the, working on one side of the bridge and the other. And the fog was so dense. And of course there's no cell phone to phone and to kind of connect with. But they had figured out when this happens, what they would do, what was the game plan. And they literally bumped into one another. They ran into one another in the fog. And got themselves out of there. But it is beautiful, isn't it? There's just the play of light. And I don't know whether there's anything after here or not. Oh, well, I put this up. This is my grandson. Now, he's much bigger than that. He's bigger than his father now. And certainly better than his father at mountain biking. And that kind of thing. But I absolutely love this because he would have been, Owen would have been, what, 5? Something like that. And they're so curious at that age. In everything gets their attention. And their next door neighbor in that barn, he was a helicopter pilot, commercial helicopter pilot. and he kept one of his helicopters in his thing. And so there he is, and I did a painting of that. I should have brought that along. That because I just love it.
Yeah.
And because of the scale
Yeah.
and the curiosity and that kind of thing. So, but he's a very different character now. So, all right, so next week we're going to, it's kind of a wrap-up time, do some really very interesting nerve things. The video next week is very good because it actually shows the surgical procedure, so you can actually see what they're doing. 2 ways of getting at the median nerve, and they explain it well. I'm really not going to play the examination of the neck. I'll tell you,
Thank you.
this should never have been allowed to live. But you know, sometimes when physicians put together things like that, they're so stilted.
Yeah.
Kind of like they are sometimes, and so not that there's anything wrong with it, not that it isn't complete, but it just is there any joy in that thing? No. So any questions, any thoughts? No? Yeah.
Question about the diagnostic indications that you've talked about, the symptoms that lead to specific sources of the
Right.
problem. Would the average general practitioner have that knowledge, or would that be that diagnosis be a result of a referral to someone more specialized?
Well, one of the reasons why I included in these things is because my general answer would be no.
Right.
I mean, I think it's very difficult these days to be a family physician because they have to know a hell of a lot more than I ever knew broad. The problem is it's thin, and they're kind of very thinly spread. And the other issue, which is a hobby horse of mine, writing it, is that it's very unusual for family physicians to visit their patients in hospital anymore. For the very good reason that they don't get paid for it. But they're also not welcome. Because the hospitals are now have become specialty houses. I remember the great battle when the University Hospital was built in London, Ontario. And when I trained there, at Victoria Hospital, which was the hospital then, before the University Hospital, it was the norm. I mean, the GPs had admitting privileges. They consulted with consultants. Well, that was all very fine when you couldn't do a lot for stuff. But University Hospital, like many other institutions that came in about that time, realized that there's no way, I mean, with the limited number of beds that they had, this was a tertiary hospital. Now, the UK had solved that a long time before, and in Europe, by very specialized clinics or hospitals. And, but, you know, the thing is, one of the great things about physicians coming together in, doesn't matter where, but traditionally in hospitals, over coffee, in the elevator, in the corridor, at the end of the day, at the start of the day, whatever it is, that's when a lot of the unscripted conversations take place about, I have a patient with such and such, and I'm not really asking you to go and see them, but I need your advice about this or that. And that's really important information. The other thing too is that the family physician learns who's good and who isn't.